Welcome to Chapter 3 of your phlebotomy course. Today we'll be discussing communication and patient diversity. Communication skills are important in any field, but probably no more such than in any form of healthcare, and that includes in the field of phlebotomy and the interactions of the phlebotomy technician as well. So communication is the process of exchanging information with others. It's a process of sending and receiving messages. People communicate by using signs and symbols such as words, drawings, pictures, even emojis. They also communicate through their behavior as well. Now, when we talk about communication, we often think mostly of verbal communication, which involves the use of words, spoken or written. When communicating verbally, it is important to use words that have the same meaning to both the sender and the receiver. Misunderstandings may occur if each person interprets the same words differently. For example, if a phlebotomist asks a patient if his veins rolls, the patient may not understand what the context of that question is. Nonverbal communication is communicating without using words. An example of nonverbal communication is a person extending his arm and rolling up his sleeve. This communicates that the patient is ready to have his blood drawn, although it's still important to explain the procedure and confirm consent before touching the patient. Nonverbal communication also includes how a person says something. For example, if a phlebotomist says cheerfully, "I'll be right with you, Mr. Gonzalez." This communicates that the technician is ready and willing to work with a patient, but is delayed at the moment. Saying the same phrase in a different tone or emphasizing different words can communicate frustration and annoyance. "I'll be right with you, Ms. Gonzalez." I think you can kind of get the difference just in the inflection of my voice on those same two messages. So as mentioned before, the simplest form of communication is a three-step process that takes place between two people. In the first step, the sender, or the person who communicates first, sends a message. In the second step, the receiver receives the message. The receiver and sender constantly switch roles as they communicate. The third step involves providing feedback. The receiver repeats the message or responds to it in some way. This lets the sender know that the message was received and understood. Feedback is especially important when working in a healthcare setting. Phlebotomists must take time to make sure patients understand their messages. All three steps must occur before the communication process is complete. During a conversation, this process is repeated over and over. Effective communication is a critical part of any healthcare worker's job. Phlebotomy technicians must communicate with supervisors, the care team, patients, and family members. A patient's health is affected by the quality of communication among the healthcare workers who care for him or her. Phlebotomists may also need to communicate clearly and respectfully in stressful or confusing situations. So, when communicating with patients, it's important to understand, identify, and try to correct for various communication roadblocks that can occur during either one of the process of sending or receiving information. One roadblock to effective communication can be the use of cliches. Cliches are phrases that are used over and over again and don't really mean anything. For example, saying everything will be fine is a cliche because you don't always know if everything will be fine. Instead of using a cliche, the phlebotomist should listen to what the patient is really saying and respond with a meaningful message. For example, if a patient is afraid of needles, the phlebotomist can say, "I understand this may be scary. What can I do to make you feel more at ease?" Instead of saying like, "Oh, it'll be over before you know it," which really doesn't put most patients at ease. So as mentioned before, in the process of communication, a lot of barriers and roadblocks can occur. One of which can be if the patient does not hear the phlebotomist, does not hear correctly, or does not understand. The phlebotomist should stand directly facing the patient. He or she should speak slowly and clearly, should not shout, whisper, or mumble. The phlebotomist should speak in a low voice using a pleasant tone. Learning Objective 5 includes information on communicating with a patient who has a hearing impairment. The patient may be difficult to understand. The phlebotomist should be patient and take time to listen. He or she can ask the patient to repeat or explain the message and then state the message in his or her own words to make sure that the they're understood. Maybe the phlebotomist, patient, and others use words that are not understood. A phlebotomist should not use medical terminology with patients. He or she should speak in simple, everyday words and ask what a word means if he or she is not sure. A phlebotomist should not use slang and definitely not profanity. Should avoid using slang words and expressions. They're unprofessional and they may not be understood. Profanity is never appropriate in any professional setting, no matter what the circumstances, even if the patient does. We spoke about the problems with cliches already. Just the simple word why or why not can put a patient on the defensive. The phlebotomist should avoid asking why when a patient makes a statement. Why questions make people feel uncomfortable. For example, a patient may say she has changed her mind and does not want her blood drawn. The phlebotomist asks, why not? And may receive an angry response, because I said so. Instead, the phlebotomist can ask, do you have any questions about the procedure that I can answer? Any concerns? Then the patient may be more willing to discuss the issue. Specific questions about the reasons for the test should be referred to the healthcare professional who ordered it, as should any questions the phlebotomist cannot answer. As far as a phlebotomist giving advice, phlebotomists should not offer his or her opinion or give advice. Giving medical advice is not within the phlebotomist's scope of practice. It can be dangerous, causing both ethical and legal difficulties. When the phlebotomist asks questions that only require a yes-no answer, that could be problematic as well. Phlebotomists should ask open-ended questions that need more than a yes or no answer. Yes or no answers end conversations and they end the communication. For example, instead of asking the patient, are you nervous about this? The phlebotomist can say, how have blood draws gone for you in the past? Obviously, a big problem is if the patient speaks a different language. If a patient speaks a different language than the phlebotomist does, the phlebotomist should speak slowly and clearly, not yell and shout, or however, he should keep the messages short and simple. Should be alert for words the patient understands and also for alert for signs that the patient is only pretending to understand. If the patient does not understand or if the patient prefers to communicate in their native language, an interpreter or an interpretation service should be used. Communication boards with pictures can also be helpful in these situations. Phlebotomists should follow facility policies when dealing with language barriers. What if the phlebotomist or patient uses nonverbal communications? So nonverbal communication can change a message. The phlebotomist should be aware of his or her body language, posture, gestures. They can look for nonverbal messages from patients and clarify them. For example, Ms. Feldman, you say you're feeling fine, but your muscles are very tense. Would you like to take a minute to relax before we begin? That's one example. In addition to avoiding these possible barriers to communication, phlebotomists need to be aware that communication can be influenced by factors such as personality, culture, and mood. Some people are naturally talkative and open even with strangers. Others are very quiet and meek and reserved. Similarly, some cultures value and encourage different styles of communications. For some people, talking to strangers, being touched by strangers, or even making eye contact with strangers is very uncomfortable, even if the stranger is of a professional level. This may be due to cultural, religious, or personal preferences. Additionally, people in healthcare settings may be worried about their state of health, and their concern can cause them to behave and communicate differently. No matter how patients behave and communicate, it's always the responsibility of the phlebotomist to follow important steps to be a communicator. So there are certain techniques and guidelines that a phlebotomist can use to help ensure that messages are sent and received clearly and completely. This involves, first of all, being a good listener. The phlebotomist should allow the other person to express their ideas completely. He should encourage or concentrate on what the patient is saying and not interrupt. The phlebotomist should not finish the patient's sentences, even though he or she knows what is going to be said. When the patient is finished, the phlebotomist should restate the message in their own words to make sure that they've been understood. Providing feedback involves active listening, means focusing on the person, sending the message, and giving feedback. Feedback might be an acknowledgement, a question, or just repeating the sender's message. The phlebotomist should offer general but leading responses such as, oh, or go on, or By doing this, he's actively listening, providing feedback, and encouraging the sender to expand on the message. Don't be afraid to bring up topics of concern. If the phlebotomist knows of a topic that might concern the patient, they can raise the issue in a general, non-threatening way. This lets the patient decide whether to discuss it. For example, if the phlebotomist observes that a patient is fidgeting or acting nervous, you could say, Mrs. Jones, you seem a little unsure about this. Understand the importance of touch and appropriate touch. Softly patting an anxious patient's hand or shoulder or holding her hand may communicate caring. Some people's backgrounds may make them less comfortable being touched. The phlebotomist should always ask permission before touching a patient and should be sensitive to her feelings or his feelings. Phlebotomists should touch patients in order to do their job. However, they should recognize that some patients feel more comfortable when there is as little physical contact as possible. The phlebotomist should adjust care to each patient's needs whenever possible. When a patient reports concerns or anxiety, the phlebotomist should have him or her repeat what they have said and ask them for more information. Any of the patient reports should be documented word for word. Do not ignore a patient's concerns. Ignoring concerns can be considered negligent behavior. The phlebotomy technician should work to understand the patient's concerns and address them if they're within the scope of practice. Patient concerns should always be reported to the nurse or the supervisor on duty if the phlebotomist is unable to address them or if they're beyond the phlebotomist's scope of practice. Never talk down to any patient. A phlebotomist should talk to patients as they would talk to any person. It's also important not to talk down or act as if the patient cannot be trusted or understand. Guidelines for communicating with patients whose situations might require special approach is found in the Learning Objective 5. And be empathetic. The phlebotomist should try to understand and identify with what the patient is going through. This is called empathy. He or she can imagine how it might feel to have strong fear of needles or blood, or to be experiencing symptoms that might indicate a serious illness. The phlebotomist should not tell the patient she knows how he feels, because you don't know exactly how a patient feels. You can say things like, I know this may be difficult, but that's about it. Throughout the phlebotomy technician's training, he will learn medical terms for specific conditions. For example, the medical term for fainting is syncope. Skin that is blue or gray is called cyanotic, and that usually indicates lack of oxygen. Medical terms are often made up of roots, prefixes, and suffixes. A root is part of a word that contains its basic meaning or definition. The prefix is the word part that precedes the root to help form a new word. The suffix is the word part added to the end of the root that helps form a new word. Prefixes and suffixes are called affixes because they are attached or affixed to the root. The prefix anti means against. The root coagulate means to clot. So an anticoagulant is a substance that helps stop the blood from clotting. The root hemo means blood. The suffix stasis means slowing or stopping. So there you go, hemostasis is the stopping of the flow of blood. When speaking with patients, phlebotomists should use simple, non-medical terms. Medical terms should not be used because they may not be understood, but when speaking with the care team, using medical terminology will help give more complete and accurate information. Abbreviations are another way to communicate more efficiently with care team members. For example, the abbreviation CBC means complete blood count, a common blood test. HGB means hemoglobin, which is an oxygen-carrying protein in red blood cells. The word STAT, which is shortened version of the Latin word stadium, means right away. Patient who's been ordered to not consume any food or liquids is NPO, an abbreviation for nil per os. That's Latin for nothing by mouth. Phlebotomy technicians should learn their facility's standard medical abbreviations. They can use them to report information briefly and accurately. They also may need to know these abbreviations to read requisitions, testing orders. Important medical terms, abbreviations, and symbols will be introduced throughout the book, and a comprehensive list is also included in the end of your chapter. There may be other terms in use at a facility as well. So it's important for phlebotomists to follow the facility policy. Remember, medical terms and abbreviations make communication between healthcare workers more accurate and efficient, but they may confuse the patients. Can't reiterate again that when it comes to communications with everyday patients, phlebotomists should use common language that the patient can understand. In almost all fields of medicine, proper procedures and documentation is key to successfully interacting with patients and protecting yourselves from liability. Documentation is the creation of a record of care given to a patient. It's an essential form of communication in healthcare. Depending on the facility, documentation might be done using computer or tablets or on paper manually. An incident is an accident or problem or an unexpected event during the course of care. It's something that's not part of a normal routine. An accidental needle stick or a patient losing consciousness and hitting their head is an incident. Other issues that must be reported including problems with specimens, containers, patient misidentification, or incorrect orders. When documenting an incident, the report is a factual, objective account of what happened. Objective information is based on what a person sees, hears, touches, or smells. It's collected by using the senses. It does not include opinions or assumptions about the causes. Now, there are legal aspects to careful documentation that are very important for the phlebotomist to remember. It's the only way to guarantee clear and complete communication among all the members of the care team. Documentation is a legal record of every part of a patient's treatment. Medical charts can be used in court as legal evidence. Documentation helps protect healthcare workers and their employers from liability by proving what they did when caring for the patients, or at least outlining what they did. A very famous lawyer said, well, not that famous because I can't really remember the person's name, but it's been very common in all fields of medicine where it was said by a lawyer that if it was not documented, it was not done. So documentation gives an up-to-date record of the status and care of each patient. Whether documenting a routine note in a patient's chart or filling out an incident report, it's very important that the phlebotomy technician follows the proper guidelines for effective documentation. For example, document procedures immediately after they're performed. This makes details easy to remember. Always wait to document until after a procedure has been completed. Do not record any care before it's been done. Collection tubes should not be labeled and initialed until a blood draw has been successfully completed and the patient has confirmed that the label is accurate. Use blue or black ink when documenting by hand. Write as neatly as you can. If you make a mistake, draw one line through it and write the correct information. Write your initials and the date. Do not erase what you have had written. Do not use correction fluid. This can give the appearance that something was attempted to be covered up and does not look good in court. Documentation done on a computer is time-stamped. It can be changed only by entering another notation. Sign your full name and title. For example, Stephen Whitlock, PBT for phlebotomist, and write the correct date. Document as specified by your facility. Ensure that patient identification, specimen labels, and requisitions match. Documentation may need to be done using the 24-hour clock or military time. We'll go over that in a moment. And remember that HIPAA guidelines apply to computer use if computers or tablets are used to document patient care. So passwords should be strong, screensavers and screen blockers should be used as well, and computers should never be left on in a public area. As mentioned before, documentation may need to be done using the 24-hour clock or military time. Regular time uses the numbers 1 to 12 to show each of the 24 hours in a day. In military time, the hours are numbered from 00 to 23. So midnight is expressed as 0000, or sometimes 2400. 1 o'clock a.m. is 0100. 1 o'clock p.m. is 1300, and so on. Both regular and military time list minutes and seconds the same way. The minutes and seconds do not change when converting from regular to military time. The abbreviations AM and PM are used in regular time to show what time of day it is. However, these are not used in military times, and specific numbers show each hour of the day. So for example, to change 4:22 p.m. to military time, add 4 plus 12. The minutes do not change, so the time would be expressed as 1622 hours. To change the hours between 1 o'clock p.m. and 11:59 p.m. to military time, add 12 to the regular time. So for example, to change 3 o'clock p.m. to military time, add 3 plus 12. The time is expressed as 1500 hours. Midnight is the only time that differs. Midnight can be written as 0000 or 000 hours, or it can be written as 2400, 2400 hours. This follows the rule of adding 12 to the regular time. Follow your facility's policy on how to express midnight. To change from military time to regular time, subtract 12. Again, the minutes do not change. For example, to change 2200 hours to standard time, subtract 12 from 22. The answer is 10 o'clock p.m. To change 1610 hours to standard time, subtract 12 from 16. The answer is 4:10 p.m. So if you remember previously, an incident is an accident, problem, or unexpected event during the normal course of care. It's something that is not part of normal routine. An accidental needle stick or a patient losing consciousness, a hitting or the head are some examples. So when an incident occurs, it's important to fill out what's called an incident report. The information on an incident report is confidential and is intended for internal use to help prevent future incidents. Incident reports should be filed when any of the following occurs. A patient falls. A healthcare worker makes a mistake in care, including collecting an incorrect specimen or collecting a specimen from the wrong patient or the wrong site, area of the patient's body. A patient or coworker makes sexual advances or remarks. Anything happens that makes a healthcare worker feel uncomfortable, threatened, or unsafe. A healthcare worker gets injured on the job, and that includes needle sticks and body fluid exposure. A healthcare worker is exposed to blood or body fluids. A healthcare worker or patient receives an accidental needle stick. A patient is injured in some way during the course of a normal blood draw. Reporting and documenting incidents is done to protect everyone involved. This includes the patient, the employer, and the phlebotomist. When documenting incidents, phlebotomists should report as soon as possible and give it to the supervisor. This ensures that details are not forgotten. So when documenting an incident, it's important to report the following. Tell what happened, state the time and the mental and physical condition of the person involved. Describe the person's reaction to the incident. State the facts. Do not give opinions. Do not write anything from the incident report on a patient's medical record. These are two separate reports. Describe the action taken to give care, and describe notification of appropriate supervisors. You want to make note of what's called a sentinel event. Sentinel event is an unexpected occurrence that results in a serious physical or psychological injury or even death. A sentinel is a soldier who stands guard. Sentinel events are called sentinel because they signal the need for immediate investigation and response. An example of this type of event is a blood transfusion error that results in a patient's death. A sentinel event must be reported to the proper agency. So one of the benefits of working as a phlebotomist is the opportunity to meet and help people of all different backgrounds and ages. Communication is more effective when differences are recognized and respected. Certain adjustments in communications can help phlebotomists when dealing with patients who have distinct needs. Let's go over a couple of definitions about some of these needs. An impairment is a loss of function or ability. It can be partial or complete loss. Special techniques for different conditions, such as hearing, cognitive impairments, will be talked about in a few moments. In healthcare, populations are a particular and distinct group of patients, whether it be elderly, pediatrics, etc. Pediatrics themselves is a branch of medicine dealing with people under the age of 18. And even then, there's a wide disparity of age differences and particular needs. Geriatrics is a very growing branch of medicine, and it's a branch of medicine dealing with the elderly population. While there's no one specific age range to define geriatrics, most sources would define it as over the age of 65. And developmental disabilities refer to disabilities that are present at birth or emerge during childhood up to age of 22. Intellectual disability is the most common developmental disability. But there could be other disabilities as well, from physical disabilities such as spina bifida, to mental disabilities such as autism spectrum disorder. Let's go over a few. There are many different kinds of hearing loss. A person may be born with hearing impairment, or it may happen gradually. Deafness is a partial or complete loss of hearing. It can occur as a result of hereditary disease or injury. In the elderly, aging commonly causes loss of hearing. People who have hearing impairment may use a hearing aid, read lips, or use sign language. People with impaired hearing also closely observe the facial expressions and body language of others to add to their knowledge of what is being said. The following guidelines apply when dealing with the patient who is hearing impaired. If the person has a hearing aid, make sure that it's turned on and that it's working properly. Reduce or remove background noise such as televisions, music, loud speech. Get the patient's attention before speaking. Do not startle the patient by approaching from behind. Walk in front of her or him and touch lightly on the arm to let them know that you are there. Speak clearly, slowly, and in good lighting. Directly face the person. Ask if they can hear what you're saying. Do not shout or mouth words in an exaggerated way. Keep the pitch of your voice low. Patients may read lips, so keep your hands away from your face while talking. If the patient hears better out of one ear, try to speak and stand on that side. Use short sentences and simple words. Avoid sudden topic changes. Repeat what you said using different words when needed. Some people who are hearing impaired want you to repeat exactly what was said because they miss only a few words. Maybe use picture cards or a notepad as needed. Some patients who are hearing impaired have speech problems and may be difficult to understand. Do not pretend you understand if you do not. Ask the patient to repeat what was said, observe the lips, facial expressions, and body language, then tell the patient what you think you heard. You can also request the patient write down their words. Visual impairment can affect people of all ages. Some vision impairment causes people to wear corrective lenses such as contact lenses or eyeglasses. Some tips involved with dealing with patients with visual impairment. Well, identify yourself immediately when you approach the patient. Do not touch the patient until you have said your name, explain why you're there, and what procedure you will perform. Let the patient know if you need to step away at any time after you've completed the blood draw. Do not simply walk away. Make sure there's proper lighting in the room. Face the patient when speaking. Always tell the patient what you're doing as you're performing procedures. Give specific directions, such as on your right or in front of you. Talk directly to the patient whom you are assisting. Do not talk to other patients or staff members at the same time. Cognitive impairment affects a person's ability to think logically and clearly. A certain amount of cognitive impairment is a normal change of aging. Illnesses such as Alzheimer's disease can cause a more dramatic form of cognitive impairment. Patients with advanced forms of cognitive impairment are likely to have family members or other caregivers assisting them as they receive medical care. But these communication guidelines are still important to remember. For one, always approach from the front and do not startle the patient. Smile, look happy to see the patient. Be friendly. Try to minimize background noise and distraction. Always identify yourself and use the patient's name. Continue to use the patient's name as you provide care. Speak slowly, using a lower tone of voice than normal. This is calming and easier to understand. Repeat yourself using the same words and phrases as often as needed. Use signs, pictures, gestures, or written words to help communicate as needed. Phlebotomists must touch patients in order to do their job, but be aware that patients may prefer being given more personal space whenever possible. Check your body language. Make sure you're not tense or hurried. Watch for nonverbal cues from the patient. Observe body language, eyes, hands, face. Ask the family member or caregiver accompanying the patient for advice about communication with the patient as appropriate. Some populations or particular groups of patients may require special attention. With all patients, maintaining a professional but welcoming approach is an excellent start to effective communication. Pediatrics is the branch of medicine dealing with people under the age of 18. Although you'd be surprised, in some facilities, in some healthcare facilities, they see pediatrics up to the age of 21. And even after the onset of the Affordable Care Act, some pediatric facilities see patients up to the age of 26, which is kind of weird, but happens. So children who are old enough to understand that having blood drawn will mean being stuck with a needle, and they may be fearful of the experience. It's important to be reassuring and take the time necessary with young patients to help manage their anxiety. Young children should be allowed to sit in a parent's or guardian's lap. As with adults patients, introduce yourself by name and title. Children can find adults they do not know intimidating, especially in a medical setting. Give the child as much personal space as possible. Lower yourself physically to be on the child's eye level while speaking. Allow the parent or guardian to hold or soothe the child, as long as it's safe to do so. The parent may also need to help stabilize the child during the blood draw. Explain to the child in a way that's appropriate to their age that you will do so in the equipment you use. Speak directly to the child rather than the accompanying parent or guardian. You actually need to speak to both. Emphasize that it's normal even for adults to be nervous about blood draws, but that it will not take long to complete the procedure. It can be helpful to give the child a job during the procedure, such as holding a hand or handling something, maybe giving the child their favorite toy to hold on to. Provide allow distractions for the child if possible. Watching a video on the parent's electronic device or looking at pictures in a book might help calm the child. Do not lie to the child about the procedure. Don't say that it will not hurt when you know it will. Take any questions the child has seriously. Answer them if they're within the scope of your practice. Do not tell the child they will get a reward if he does not cry. If your facility offers rewards to children, do not make brave behavior a condition of the reward. It's normal for a child to be frightened. Geriatrics is the branch of medicine dealing with elderly patients. Older patients may have hearing, vision, or cognitive impairments, or they may not have any impairments at all. It's important not to make assumptions about this group of patients. So guidelines would include treating older patients with the same respect you give all patients. Do not talk down to them or treat them like children. If an adult child or other caregiver is accompanying the patient, it's appropriate to answer any questions they may have. It's important to communicate directly with the patient themselves. Speaking only to the adult child or caregiver is disrespectful and suggests that you do not believe the elderly patient is able to understand and communicate for themselves. They lose their autonomy. Call elderly patients by their proper names. Do not use terms like sweetie or dearie. the patient indicates that he or she has an impairment of some kind, follow the appropriate guidelines listed above. As mentioned before, intellectual disability is the most common developmental disability. An intellectual disability is neither a disease nor a mental health disorder. People with an intellectual disability develop at a below average rate. They have below average mental functioning. There are 4 different degrees of this disability: mild, moderate, severe, and profound. Depending on the level of disability, a person may have a legally designated representative for issues such as medical consent. Some guidelines for dealing with this population would be to 1, as always, introduce yourself by name and title. Describe the procedure you'll perform, watching for indications that the patient understands. Treat adult patients as adults regardless of their intellectual abilities. Give the patients the opportunity to ask questions. Answer questions within the scope of your practice. Remain calm and patient even if there are repeated questions. Watch closely for nonverbal cues that the patient is confused, unsure, or anxious. Slow down and reassure as necessary. Autism spectrum disorder, or ASD, is a type of developmental disability that can result in differences in how people relate to others and communicate. Patients with ASD may seem withdrawn and may find communication challenging. They may not be comfortable making eye contact or speaking to unfamiliar people. New situations can be overwhelming for a patient with ASD, so it's essential to treat them with empathy, patience, and respect. Now, according to the U.S. Census Bureau, over 15% of adults in the United States speak a language other than English in their homes. In some communities, the number is much higher. As noted in Chapter 2, patients have a right to receive information about their medical care in the language they understand. Healthcare settings can be difficult to understand and even frightening, no matter the language a person speaks. This is especially true for patients whose first language is not English. So some guidelines for patients who are non-native speakers of English include: 1. Be familiar with the interpretation services available at your facility and use them when they are needed. Watch for signs that a patient does not understand what you're saying. Sometimes people who are afraid to ask for help when they do not understand. Do not rely on a patient's friend or family member to translate medical information. You should really be using an impartial third-party service. If you live in an area in which a particular language is spoken, learning some simple phrases in that language can help put a patient at ease. Most patients a phlebotomist works with are likely to be polite and easy to work with. Occasionally, however, patients might pose more of a challenge, whether due to illness, anxiety, frustration, or personality. Patients may display combative, meaning angry or hostile or inappropriate behaviors. The way the phlebotomist communicates in these situations can determine whether the situation improves or worsens. Sometimes the best choice is to get help from a supervisor. If the phlebotomist ever feels threatened or unsafe, they should leave the situation and contact the supervisor immediately. But in other terms, some tricks of the trade to deal with combative, angry, or inappropriate behavior is to: 1. Stay calm. Do not argue or respond to verbal attacks. Allow the patient time to calm down. Make sure you lower your tone of voice. Be flexible and patient. Try to find out what's causing the patient's behavior. Using silence alone may help the patient explain. Listen attentively as the patient speaks. Stay at a safe distance if the patient becomes aggressive in their mannerisms. If there's any evidence of the patient wanting to be combative, leave the scene immediately. If a patient makes an inappropriate or sexual comment, address the behavior directly, saying like, "That makes me uncomfortable," or "I find that unacceptable." If the patient persists, call for help immediately. If a patient attempts to physically strike you, get out of the premises. We'll talk a little bit about patient interaction and violence in the healthcare setting. If you happen to be struck by a patient, leave immediately. If you strike a patient back, that is not necessarily considered self-defense. That is considered retaliation, and you can be held liable. Just always know that. Always report inappropriate behavior to a supervisor, even if you think it was harmless. So that's the chapter 3 as far as communication techniques that we'll go over in class. Please review the slides, review the presentation, and make sure you have your homework submitted on time as outlined in your syllabus. Until next time, take care.